Excellent. I appreciate it. Thank you so much. And I really appreciate the chance, the opportunity to come back this year. And I really enjoyed it last year. I wish I could be there today with you guys, but unfortunately, some stuff had come up out here, so I have to stay in this area. And number two, Bob, congratulations on that retirement. I'm going to miss you. We've had some really nice talks here in the past couple of years, and I really appreciate it. And you guys have done a great job, excellent job of the Seattle Science Foundation. And I've really enjoyed the talks over the years. So thank you so much. So today, what I'm going to do is we're going to talk it's a follow-up of the talk that we had last year, talking about the complex spinal deformity. We're going to be showing and talking more about the long-term data that we have that's come out, and plus some more of the biomechanical studies, because I know a lot of questions have come up. So as we've talked about in the past, rod failure, rod fractures has been a huge thing, especially when we're talking about complex spine deformity cases. On a simple virgin spine, we're seeing up to 9% of failures on these rods within 1 year. And on any type of complex deformity, PSO, Smith-Peterson osteotomy, there's data out there that shows up to 22% failure on these rods. So that's a huge morbidity, a huge thing, not only for the patient. They have to go through that pain again. They got to go through the psychological stresses of the revision surgery, the loss of correction, and not only to say the financial burden to the patient taking off work and having the financial to the hospital and everybody. So it's been such a big ordeal, from that standpoint. This essentially led to the studies, the laboratory studies of the MoRe, and this is kind of how they came up in the lab, the engineers looking at these alloys. And essentially, they knew that in the laboratory testing, the combination of the molybdenum and rhenium, which is known as the MoRe alloy, had vast superior strength and fatigue endurance limits when compared to titanium and cobalt chrome. So the question came down, would this be applicable, and can this be utilized in the human body? Specifically, would it be applicable to be utilized on complex spinal deformity cases? So as I talk to my patients ahead of time and my students that come through here, the medical students, the success of a spinal fusion or any type of fusion, long bone, tibia, rod, anything, it's a race against time. So we know that if the bone doesn't fuse, the bone doesn't heal, any hardware that you put in the body is going to fail. So the question is, can we put in some type of alloy in there and hold the alignment long enough to obtain a successful fusion? So that's essentially dependent upon 3 areas that I break it down. Number one, the surgeon, as Dr. Shafi put out very nicely this morning, that's the training, the carpentry. Do you perform the adequate alignment to get the procedure to get the sagittal and coronal balance? Number 2 is osteobiologics. And there's a slew of those. I just call those a lighter fuel. You could use whatever you prefer to use, and hopefully that'll stimulate the bone growth. And number 3 is essentially the alloy. To date, for the past 50 plus years, we've had the combination of the stainless steel, the titanium, and the cobalt chrome. And it wasn't until recently, after 50 years, that the FDA approved this new alloy, the MoRe alloy, to be utilized in the human body. So this is a retrospective study that we're going to be presenting. I'll be presenting in a month or so up at the CNS conference. Unfortunately, we didn't have enough data. The company didn't have enough data to support it at the SRS because you need a minimum of 2 years. So this is a retrospective study of looking at multi-level complex spine cases at 10 different facilities throughout the United States. The only criteria was it had to be greater than 4 levels, greater than 18 years of age, and data collection at the time of 6 months or longer, looking at radiographic images, i.e. for rod failure, fracture, or loss of alignment. That data now stands at 23, almost 2 years follow-up. Here you can see the results. To date, 0 rod failures. And 10 different facilities throughout the country. as you can look at the parameters, you can clearly see none of this was picking and choosing. Everybody's included. We had 31% smokers, osteotomies, 39% Smith-Petersons, 24% PSOs, and all of these patients were stabilized and fixed with a 4.5 millimeter rod. So that's pretty impressive, especially when you look back at that first slide that I talked about, that we're talking about 22% failure rates with osteotomies. If you just do the math calculation, by definition, we should have had anywhere between 15 to 25 failures on this data. So pretty impressive data when you look at that. These are the critical rods. So, I get asked, and, why, what are the properties, the mechanical properties of the molybdenum and rhenium? And the key, both of these have unique properties, but rhenium especially has a very unique property. And I could tell you that rhenium is utilized a lot in space. NASA uses it for their shuttles because it can sustain such strenuous heat and pressure changes. So if you look at the slide on the left side, both of these are static testing versus dynamic testing. So these are the static testing slides. And if you look at the one on the left, that's the force displacement. And you can see what is being tested, what the engineers tested on these two slides is essentially the alloy. We're not talking about a rod. I want you to think about it as the alloy, the simple alloy alone. And you can see that the alloy had a far superior force displacement data collection compared to cobalt, chrome, or titanium. When you look at the slide on the right, that looked at stiffness and yield strength. And you can definitely see there that on the right that the molybdenum and rhenium had a far higher stiffness and yield strength. So when you look at it from that perspective, you can say, oh, yes, well, it had much stiffer rod or not. But what that has allowed the engineers to do is to make the rod smaller. So specifically what they have done now is they've been able to take, because these rods were all 5.5 when they're looking at this data, so they've been able to drop the rod down to a 4.5, and now the yield, the stiffness has dropped down to actually below the cobalt chrome, almost equal to a 5.5 stainless steel, yet they've been able to preserve the strength. So we have a rod that's much smaller that has the strength, but actually has less stiffness than a cobalt chrome rod. And that's a key feature, because it's hard to tell somebody, it's hard to explain to a surgeon or anybody that you have a 4.5 millimeter rod that is going to be less stiff but stronger. But that is the alloy, and that's why I want you to think from an alloy perspective. We're not comparing the same things here. We're two different aspects. So we have a stronger rod, but a less stiff rod when we're talking about the alloy. Now, this is the key data here. This is the dynamic testing data. Now, when you look at the dynamic testing, and this is what really where the new alloy has vastly been superior to the cobalt chrome and the titanium alloys, because of its endurance. Again, and this is why NASA uses it up in the high pressure, the shuttles, because it doesn't fatigue, it doesn't fail. You can imagine if you had something up there at those high pressures that failed, we would have a lot of, data coming back at us that, why did this stuff fail and, be catastrophic. So what this shows here, what the engineers, they tested two different endpoints. Number one was failure of the rod versus number two, 10 million cycles. So if you look at this graph, and let's take the example at 100 KSI, kilopounds per square inch. And if you look at the 100 line right there on your left, you'll see that the cobalt chrome rod, titanium rod failed. They never made it above those fatigue strength levels. Versus the MoRe rod tested far superior to that, and it made it out to 10 million cycles without fatiguing at a KSI around 130 plus, versus the other ones were fatiguing, getting down. It took them less than half, almost a third of the fatigue strength of the MoRe rod. So This is key when you're talking about why are these rods not failing like the cobalt, chrome, and titanium. The only way that a titanium rod or a cobalt chrome rod can retain this data of fatigue failure would be to increase the diameter of the rod. So you'd have to take a 5.5 titanium or cobalt chrome rod and make it a 6.0, or go to it exactly what we're doing now, like we talked about at the SRS last meeting, is making 4-rod construct, 6-rod construct, putting a kickstand, because we're trying to regain the fatigue and preventing that alloy from failing. So this is key data here, is that you have a rod that you could still have the stiffness, but it's not failing at these $10 million cycles. And that's a hard thing to comprehend or to see, because we're not used to that. We're so used to the 5.5 rods and the 5.0 and up to the 6.0 rods. So the other issue that came down that is quite impressive is the breakdown. This is what we see in the media all the time, commercials, TV, lawsuits, you name it, is the microparticles of the breakdown of the hardware. And if you look at the hardware, the cobalt chrome, you see the PDE, which is the permitted daily exposure, well above 914% above the PDE. Titanium, 47%, versus the MoRe rod, when you break it down to molybdenum and rhenium, both of those are well below the permitted PDE levels. So we're not seeing, when I say we, the engineers are not seeing the microparticles that they're seeing in the cobalt chrome and the titanium. So taking this data, and I've been using this hardware since 2019. So basically early 2020. So I'm going to show you some of my case studies. I have some new ones, and I have some follow-ups, and I have some data from the group that been looking at this stuff. So this is a 61-year-old male that I presented last year. Refer to me, flat back. You can see you have sagittal imbalance. Went in, took everything out. Here you can see his clinical pictures. Went in there, did a PSO on him, put an expandable cage right above, 2 4.5 millimeter rods, and now this is a 2-year follow-up data. And you can see no breakdown at the top, no PJK. Here you can see the 4.5 rod looks awfully small, but that's a 4.5 rod there as I'm doing my PSO. And then you can see the close-up. Here's this 2-year follow-up post-op. Here's the second case, 57-year-old female, 3 prior surgeries, coronal sagittal imbalance. Went back in there, PSO, 2 4.5 millimeter rods. This lady is 3 years out, still nice alignment, no rod failures. Didn't have to, and you can see an extensive amount of bone graft in there. So what exactly happens to the rod? So, we get these rods, any rod, any piece of metal, any alloy. So we take the straight rods and we go in there, we start bending it, we contour it. So what are we doing from a micro perspective? Every time we use a rod bender, every time we put a cap screw in, every time we compress and distract across the rod, we're causing these micro particle tears into the rod. Okay, we're notching the rod. All of these notches are essentially a setup for a rod failure. So these are 2 slides. These are 3-point fixation or 3-point bending tests. Cobalt chrome obviously on the left side, titanium on the right side, and you can see the data in the middle, and just kind of watch as the rod goes down, and you're coming down, and you can see on the left side that the cobalt chrome already snapped if you look closely at the top there, so that failed. Watch the titanium. You're going to see the rod straighten out there here shortly, and that rod's got right there. You can see that failure. So the titanium rod, these are 5.5 rods. The titanium rod did a little better than cobalt chrome. It broke at approximately 11 millimeters versus the cobalt chrome failed at around 6 millimeters. Now look at the molybdenum rod, the MoRe rod, and you can see this coming down here. And same thing, for the purpose of the testing, all the rods were the same. And you can see this rod coming down, and you'll see it continue to bend. But I can tell you the rod doesn't break. And you can see the data at the top there, at the very top. And the rod went down to 14 millimeters and never broke, never fractured. So So what they did next after this, they took the same rod, they notched it. You can see down at the bottom on the right side, and they put a good sized notch in the rod prior to putting it on the 3-point fixation test. They locked the rod left and right this time, as opposed to keeping it loose like they did on the previous testing. So they're really kind of challenging the rod here pretty extensively. And you can see, even with the rod that's been extensively damaged prior to the 3-point bending test, I can tell you this rod doesn't break. And you're going to see it coming down here. And you can just see that it's giving, giving, and giving. So again, this is critical when we're talking about PJKs, because these rods are not stiffer. They're able to sustain, they're holding their alignment. You know, they're stronger, but not stiffer. Big difference. When you're looking at the data here from the 3 rods side by side, all of us have bent rods, cobalt, chrome, and titanium, stainless steel. And you know, as you bend that rod, there's a give to the rod, and we essentially call that the recoil. And you kind of have to overcompensate. You have to overbend the rod to let it recoil back again. And you can see on the titanium on the side there, you can see the cobalt, chrome, and then minimal recoil on the MoRe, which is key, especially if you're doing deformity cases, because you could contour that rod to where you want to have it, and it's going to hold into that position. You know, I do have a rod here with me on the side here. I don't know if you can see this, but people are asking how stiff is this rod? I mean, and this is one hand, and I'm just bending this rod. So I don't know if you guys can see that or not, but this is not a stiff rod that you would think. I can tell you a 6.0 cobalt chrome or a 5.5 cobalt chrome, which I used to use, would be a much stiffer rod than bending this rod. So that's the notching. So, and that has allowed, this is another follow-up of one of my cases, it has allowed us to really address some of these osteoporotics. I'm down in Florida, and I deal with a lot of severe osteoporosis and mostly revision cases, which is what my practice is. We do a lot of PSOs, a lot of Smithsonian. We used to. I'm going to talk about that here shortly. But look at this rod that this case I did here. This is an offset PSO that we ended up. And I'm putting these crazy bends in the rod at the bottom there. You know, when I used to put this in, I would have to, you know, put a 3rd rod or quad rod construct down there at the bottom for fear that I notched that rod like crazy, and I would be anticipating a rod failure within a year. But now we can go ahead and make these type of crazy bends, you know, because a lot of times on these cases, you lose a pedicle, though I'm putting a pedicle screw in. And so I'd have to go more of an outside in type approach or leave a pedicle way out. And as opposed to putting on a different construct, I can now safely bend these rods and capture that saddle. And so far have not had any issue with these rods failing on me, you know, where, you know, my personal data for 4 years. So what has this allowed? Using this new alloy, with the engineers have been able to make thinner, smaller, yet at the same time stronger plates. Now, I can tell you they're down, this is a 4.5 millimeter rod that I just bent, but the data, talking to the engineers recently, is that it's more of a 4.2 millimeter rod. So theoretically, from a biomechanical standpoint, this rod can even be made smaller to make it compatible with titanium and stainless steel, or titanium and cobalt chrome. But it's kind of hard to explain to somebody that we're going to put a 4.2 rod in, because the whole concept. Posterior cervical is down to 2.7 or 2.9 in development. And this is very interesting, because there are obviously going to be a lot of surgeons that still want a 5.5 rod or 6.0 rod or a 5.0 rod. So this alloy, the thing that's pretty impressive about this alloy is that this is mixed. The powder form is mixed in the lab, and they're going to be able to make these customary transitional rods. So if you're a surgeon who wants to have a 5.0 rod at the osteotomy site, you're going to be able to do that. So let's say you're going to use a 200 millimeter rod, and you say, I'm going to put my osteotomy at the L4 level. So between 140 millimeters to 160 millimeter rods are going to be my osteotomy site. You could put a 5.0 rod there, and adjacent to it have a 4.5 rod, or transition, if you want to go up into the cervical, to a 2.9 rod. So it's pretty impressive when you look at this data on this alloy and what can be done with it. As far as the plates go down, the cervical plate is down again because you can get away with that, 2 millimeters. Foot and ankle, this is the 1 millimeter plate that I have here. That I know that was launched recently. I don't do any foot and ankle, but I know that was launched. Again, these are the reason I'm talking about this because these are properties of the alloy. Again, we have to think outside the box because we're dealing with a new alloy. So we can make these down to, they can make these down to 1 millimeter and still have the same strength and no change in the stiffness from these. And my favorite, which I use all the time, are the expandable cages. Now, this has been a game changer for me. So the expandable cage, and again, I do a lot of deformity cages. What they've done with this is use that alloy, the MoRe alloy, into the internal struts, the jack part, the internal organs of this alloy. Because of that, again, they could go smaller yet stronger. They've been able to lower this expandable down to 3 millimeters. Yet at the same time, you obtain the height up to 16 millimeters upon full expansion and creating up to 24 degrees of lordosis. Well, why do I say that? Because that's key. For somebody who does a lot of PSOs like myself or Smith Peterson, it's been a game changer for me because I've been now able to rely on using more these type of devices in my reconstruction in my thought process. This is a case that I did around 2 to 3 months ago. I guess it's 6 weeks ago, but I just saw her back for a 6-week follow-up early this week. And you can see that we have a sagittal imbalance. She had 2 prior surgeries, a corpectomy T12, and then they took her down to the L5 level. And if you look closely on the left, you can see that she has a cage that subsided at the L4, L5 level, and she has minimal disc space at L5S1. So I went in the game plan of doing a PSO on this level to take out and do a PSO at the L4 level, do my reconstruction. As I started working on her and I started loosening her up, I said, well, this is, I think we can slip a cage inside there. So I lift her up, I loosen her up, and I was able to put an expandable on top. And if you look at that middle or the far right one, you can see that that cage is sitting on top of that expandable cage. And I just packed a bunch of graft material in and lifted her up. And again, 4.5 millimeter rods here. You can see my post-operative films. Dramatic blood loss, less blood loss on this lady. And she went home in 3 days post-surgery. So saved the PSO, got the alignment I was hoping to get, and she actually went out of the hospital in 3 days. Here's another case, 43-year-old male with a grade 2 spondy right there. And I was able to, you can see the CT scan, and then I was able to put in that expandable and retain the height back on that. So my observation from my personal data is that my number, when we look down and at our data, is from, I've been in practice for 22 years. I trained with O'Brien and Tom Lowe, so we were big deformity guys, back then. So anyway, I've seen a dramatic reduction in my number of PSOs over the past 2 years, past 3 years, and I've only had 1 PJK in the last 3 years. So that and this data, we'll be looking into that, but this data is essentially backed up by the data of the 10 facilities that we've been, that article that we came out that we're going to be presenting. We've all seen a pretty dramatic drop in the PJK again. And we do strongly believe it's because of that alloy, the property of that less stiffness, not the more, less stiffness from the alloy that we've been utilizing. This is a case study that I want to show. This is one of our worst nightmare cases. You see this dramatic kyphotic deformity at the top. So this is a lady I presented last year. I wanted to show you some follow-ups on her. Once again, I did a PSO on her. I told her when I was done, I said, this is probably going to fail. I'm going to have to take you up into the upper thoracic region. We're 2.5 years out now, and this lady still has not failed. So an osteoporotic lady with extreme upper thoracic kyphosis, getting up to that level, I was very pleased with that and the data outcome. So in concluding, Again, engineers have found that when you compare the 4.5 MoRe versus the 5.5, we have definitely a stronger alloy. It's equivalent to the 5.5 titanium as far as stiffness, but actually less stiff than a 5.5 cobalt chrome. The data supports that a 4.5 can even be dropped down to a 4.2 if you wanted to have a smaller rod than that. Obviously, the smaller rod, the more bone grafts you can put in the case. The fatigue, which is a critical thing, the key component of this is that it's 4 times more durable. That's why we don't think they're seeing the rod breakage. The 3-point bending test is 3 to 5 times less recoil, which is nice. You can bend that rod into the deformity and it kind of holds that deformity. You could counter, you can bend it like I showed you on my slides to get those awkward pedicle screws that you leave out on the side. And the notch sensitivity has been dramatically reduced or concerned with this. The ion release levels and well below the percentage of the permitted daily exposure. The challenges are obvious. It's hard to sit here and talk and present data, and especially when you go into the SRS and we're talking about 4, 6 constructs and say, hey, we could put a 4.5 millimeter rod and that's going to be vastly superior than a 4-rod construct. But all we can say is that the data is showing that this is superior, and the biomechanical studies are showing that this is a stronger rod and less stiff, and we're not seeing the rod failures that we've seen with the 4.5 rod, and we're not seeing the PJKs because it's not as a stiffer rod. So that's something that has to be, I think time will, once we see more data out there, that's obviously going to be the results. That's what we have to show. I mean, that's what people are going to see. So this, you sit there and look at this guy, and I personally would look at this guy and think I'm absolutely crazy. And I'm sure a lot of you guys are thinking, why in the world would you even be touching a 585-pound patient? Well, this is one of my nurses at the hospital. 6 months ago, he had to stop working because of the pain. He went through pain management. We sent him up to the bariatric surgeon, and we had a conference call between the primary care doctor, the bariatric surgeon, and myself. And he said, Steve, I really need you to do something. The bariatric surgeon, I want to do a gastric sleeve, but I got to get this guy moving. Can you do his spine? Can you fix him 4.551? And then we'll do the sleeve and we'll get this guy going. And that's what we did. So I would never have thought in my wildest dream to put a 4.5 millimeter rod on a 585-pound patient with 2 expandable cages, 5 years ago. I think Michael Bryan and Tom would look at me and say, what in the world are you doing? But obviously this is what we did. I could tell you he's doing well. He went out and he had his gastric sleeve. We saw him for his 3-month follow-up. He's moving along well. I think, he's encouraged and he's making definite good progress. And we're hoping to get him back into the hospital within around 6 months from now, once he gets some of that weight off. But that's it. This is the alloy rod. If you ever go up you'll see this rod there. This is a rod that sits at the table. It's been over 500 times that every surgeon has come in, engineers come in, they bend this rod, see if they can break this. Yet today, nobody's been able to break this 4.5 millimeter rod. But thank you very much. Appreciate it.
Great presentation, Steve. And I have to say, it seems counterintuitive to me that it's more resistant to rod fracture and yet not stiffer. But where are we with the clinical data? I mean, is it just your data so far? I mean, I think that's something that I think that's going to be met with skepticism, and I'm worried about it a bit in my own patients.
No, I appreciate that. No, that's why we had that data. I'm not sure. I know you had to step out there, but we have that data that we showed at the beginning. We're going to be presenting this at the CNS in 3 weeks. We did a retrospective study with 10 facilities and basically 159 patients at 10 facilities throughout the country at the time of the 6-month follow-up, because this data was collected 2.5 years ago. We're at 2-year data now, and we have no rod fractures of any of the facilities. So that's not my data, that is throughout the country. And those were only the data that had 4 and 5, 4 levels and above. So that was a multi-center retrospective study, no restrictions, osteotomy, smokers, everybody was included in that data.
Right.
And that data showed zero rod fractures.
And 0 PJF?
And I personally had 1 PJF. We didn't look at PJFs, but my data from the 4 years that I've been doing this, I've had 1 PJF that we went back and we fixed that. But again, the mechanical studies show that this is a stiffer rod, a stronger rod, but less stiff rod. Because when you drop it down to 4 or 5, it's not as stiff as cobalt chrome. So it's 10% less stiff than cobalt chrome.
Right. And what about the possibility of failure at other locations with the rod not fracturing, like screw loosening or screw breaking or dissociation of the head? Any of that?
We have not had that happen. We have not had that happen. And we keep pretty close ties with those 10 different facilities, because obviously we don't want this to be a biased data that I'm presenting. And I'm not going to go to the CNS and present data just but none of us have from the follow-up at 2-year data now, any of these failures. Yeah.
Fantastic stuff. Any questions, Roland?
Yeah, Dr. Enguidanos, this is Dr. Roland Kent. Great data. I really appreciate the presentation of the mechanical properties of this alloy. I think it's incredible. It really resonates with me, and I wanted to get your thoughts. I mean, we look at the mechanical properties, we see less stiffness, but less likely to break, et cetera. Could you comment on your thoughts, or whether there's any data as to less stiffness, less stress shielding? Does that aid in the accomplishment of fusion?
Yes. My personal thought is yes, because first of all, if you have motion, that's what's going to lead to fatigue, failure of the hardware, and fail. And that's where you're going to get your rod breakage, and you're going to get your non-union, your pseudoarthrosis. So, as long as we can hold that fusion alignment, and we can hold it, and we get the bone graft, the osteobiologics, a chance to incorporate and fuse, then, that's our goal. That's our, so we are seeing, it is a ductile, but it is a stiff rod similar to the cobalt chrome of the titanium, not as stiff as cobalt chrome, but stiff, just equivalent to titanium. So it's holding those rods, it's holding that alignment, and there's less recoil. So, it's exactly what you're putting in, and it's giving those biologics a chance to fuse. So, and again, that's why I believe, and I can't speak to NASA, but I mean, that's why they're using it in the space shuttles, because of that less failure rate, and it's holding it what it has to get done to, at those high stress pressure, those high, demands that they're placing on it. Did that answer your question?
Yeah, I mean, I agree. We look at stress strain curves in the fracture model, and I know it's hard to use a fracture model and say that this applies directly to spinal fusion, but I often think that with too much stiffness in our constructs, that then we provide stress shielding and actually cultivate pseudoarthrosis. It seems like this approach is actually more favorable as far as stress strain curves are concerned. I would love to see the data over time as to whether we're seeing higher fusion rates at each of the levels associated with this, and I'm sure that's forthcoming.
And I agree with you 100%. And that's why it's going to be nice to have a transitional rod, because then the surgeon is going to be able to manipulate and say, okay, if I want a little bit more play at the top, I can go down from a 4.0 or 3.5, a 2.7. So you're going to be able to transition. When you think about the straight, let's talk about general orthopedics. I mean, what do you do if you have a tibia non-union? We dynamize it. We take it out and we go less stressful, and we dynamize. We want motion to get we want those osteoblasts to make bone. It's almost counterintuitive, but we're going in the opposite direction. We're making these spinal fusions stiffer and stiffer and stiffer by putting more and more rods in there at the cost. And are we achieving a fusion, or are we doing a fusion by hardware? And, I've had plenty of discussions at the SRS and with engineers about this. I think we could get a fusion by hardware by putting more and more rods in there, but is that the best approach? Or do we put a rod that contours and holds the spine, and then we let the body, the osteobiologics, do their job and make bone and get a fusion by, bone?
Yeah,
Great
points.
work. Thank you.
Any questions online, Amir, or any comments?
Yeah, no, I think this is a great talk. Obviously, cutting edge stuff here, and I know you've been able to use it. I would love to kind of try to incorporate this, especially in those cases where you worry about fragility and overly stiff constructs. I think that's something maybe we don't focus on quite enough.
Right.
And I agree, and I think that is huge, and that's why I like this alloy down in Florida, because my age population, I think you guys know, it's if you look at the average age of my patients, much older. So the osteoporotic patients, I mean, we see those. I mean, from that standpoint.
Yeah, I've heard Florida called God's waiting room by a spine surgeon that I won't name, but fantastic talk. Thank you so much. And are you going to be out here for SRS?
I'll be there. I'll see you in a couple of weeks. I definitely will be out there. And again, I apologize. I would have loved to have been there. I would like to see you guys, and had a great time last year. And I really appreciate this opportunity.
Yeah, no apology needed, and we all understand our schedules, and look forward to seeing you next week. I should say Miris is hosting a reception Thursday night, 7 to 9 p.m. at the hotel during SRS. So anyone that's interested in further conversation around this technology should come visit. So thanks so much, Steve.
Thank you. I appreciate it. Thanks, guys.
Thank you.